Delirium. Delirium is the most common neurologic problem among all critically ill patients, affecting 60% to 80% of population. Delirium is associated with worse intensive care unit mortality, higher length of stay, and a risk of permanent cognitive disability. Some data even show worse mortality in the long term. Cognition is the most metabolically demanding process in the human organism and is easily disturbed by systemic or neurologic pathology. Medications or the routine of ICU care. Often sedation induces a state of delirium that lingers longer than expected or desired. Definition. Delirium is defined as an acute change in global cognitive function affecting attention, arousal, orientation, or perception. The course is usually fluctuating and symptoms often worsen at night, called sundowning, even in those without any pre-existing dementia. Knowing a patient's baseline cognitive ability is essential as delirium must be distinguished from dementia, a chronic problem of impaired cognition and neurologic emergencies, that is herniation, producing an acutely decreased level of alertness. There are two types of delirium, hypoactive and hyperactive. Patients with hyperactive delirium, previously called ICU psychosis, may be loud, agitated, or combative, eliciting a high degree of attention from staff. They often require medical and physical restraint and may not perceive the medical staff as trying to care for their well-being. Although hypoactive delirium is more common, particularly among the elderly, it tends to be overlooked. These patients may be quiet or sleepy yet profoundly confused and disoriented. Monitoring for both types should be routine for all ICUs. The etiology of both types is often the same. Although they may be more difficult on the medical staff, patients with hyperactive delirium have a better prognosis. The assessment, first history taking. You have to take the full history about chronic dementia or psychotic illness, or it is a new delirium. Chronic dementia comes under chronic disease and acute is new delirium. Neurologic examination should be done. Vital signs, glucose level. We exclude pain and agitation. Low glucose trauma can cause delirium. Fever and meningismus to rule out. Blood, urine culture and sputum cultures to be taken. Chest X-ray and lumbar puncture must be done. If there is any head trauma, CT scan of the head to be taken. And if there is seizures, EEG must be performed. If there is signs of herniation, monitor is the treatment. Neurosurgical evaluation must be done and treat the elevated intracranial pressure. If low glucose trauma, thiamine and D50 must be administered. Non-focal examination include medication review, correct environmental factors, CBC, CMP, complete metabolic panel, magnesium phosphorus level and urine toxicology screen, drug levels and urinalysis. ECG, X-ray must be done, thyroid profile, rapid plasma regain, B12 level, ammonia level. And if no cause found, still we have to find some other investigations, neurologic consultation, lumbar puncture, EEG, electroencephalogram and MRI brain, magnetic resonance imaging. Risk factors for delirium: age, baseline dementia or cognitive impairment, psychiatric comorbidity, history of alcohol and or drug abuse, low albumin and malnutrition, psychosocial stress. Example, death of a spouse, hearing or visual impairment, sleep deprivation, history of multiple medical problems. Causes of delirium: vascular causes, stroke, hemorrhage, irreversible posterior, leukoencephalopathy, vasospasm, migraine. Toxins, medications, alcohol, illicit drugs, occupational exposures, withdrawal. If it is seizure, The causes will be aura, ictal state, non-convulsive status, epilepticus, postical state. Other organs, hepatic, uremia, cardiac disease, lung disease. If electrolytes, hypoglycemia, hyponatremia, hypocalcemia, hypomagnesemia. Neoplastic, primary tumor, metastasis, carcinomatous meningitis, paraneoplastic syndromes. If it is infection, urinary tract infection, pneumonia, meningitis, encephalitis, sepsis. Trauma, under trauma, direct trauma, edema, diffuse anoxal injury, post-concussive syndrome. Autoimmune disease, under this neuropsychiatric lupus, Hashimoto encephalopathy, CNS vasculitis, limbic encephalitis. Endocrine, under this hypo and hyperthyroidism, hypopituitary state, hypoparathyroidism. Hyper or hypoparathyroidism. Nutritional, vitamin B12 deficiency, Wernicke encephalopathy, that is thiamine deficiency, and Machia-Fava Bignami disease. MACHIA, Machia-Fava, Machia-Fava Bignami, BIGNAMI, Machia-Fava Bignami disease. Medications that can cause delirium during use: anticholinergic agents, sedatives, antiemetics, antipsychotics, antispasmodics, tricyclic antidepressants, muscle relaxants, digoxin, cimetidine, anticonvulsants, corticosteroids, lithium, benzodiazepines, barbiturates, opioids. Withdrawal. What are the medication when it's withdrawn? The cause of delirium are appetite suppressants, cough or cold remedies, alcohol even without delirium tremens, selective serotonin reuptake inhibitors, nicotine, baclofen. And non-medical causes of delirium: disorientation, frequent disorientation. So the treatment will be frequent reorientation. Sleep cycle change. Treatment: provide stimulating activity, keep out of bed during day, no interruptions at night. And the third cause, sensory deficits. The treatment will be put on glasses, hearing aids. Fourth one, poor communication. Treatment: communication devices. Fifth one, catheters and restraints. The treatment will be remove catheters, tubes and restraints as early as possible. Sixth one, dehydration. Assess for dehydration and hydrate the patient. Seventh one, malnutrition. Feed the patient parenteral nutrition if needed. Pain. Treatment: assess for pain and treat the pain. Tenth one, immobility. Remove restraints early, range of motion exercises, keep out of bed. And if the cause is urinary retention, treatment will be place a bladder catheter or start scheduled catheterizations. 12th one, constipation. If there is a constipation, treat with disimpact if needed. Start bowel routine, and if there is fever treated with antipyretics scheduled if necessary. And infection, if there is infection, search for blood analysis, microbiology, culture and sensitivity test, and treat the underlying infection. And if the cause is hypoxemia and hypercarbia, check arterial blood gases level, ventilate or oxygenate as needed. Treatment for delirium. A methodological and thorough approach will help identify the cause of delirium in most cases and should guide the treatment. However, the useful technique to combat the contribution of delirium that is due to simply or to the routine of being in ICU include family members bringing in familiar objects, glasses, hearing aids, clocks, calendars, photographs of friends and family, and regular reorientation of the patient is needed. Placing patients in rooms with natural light helps restore normal sleep-wake cycles, and if possible, limit stimulation at night. The second one is redirection is always the first option, followed by softer restraints. And although atypical antipsychotics are becoming more popular, haloperidol is still the most commonly used medication. A scheduled regime is more effective than as needed dosing. A more prudent approach is to evaluate for delirium, pain, and anxiety separately and treat each specifically. Thank you.